the clinical experts of heart failure management. The agenda of the today's meeting is our speaker, the Dr. Akshay Desai sir, will talk on recent updates in the management of heart failure with reduced ejection fraction, which is followed by the panel discussions, question and answers. It's my great pleasure to introduce our today's speaker, Dr. Akshay Desai. He is the Medical Director, Advanced Heart Disease Section, Cardiovascular Division, Brigham and Women's Hospital, Boston. He is the Principal Investigator for Evaluate HF Trial and Investigator for the Paradigm HF Trial. Today on our board, we have the eminent cardiologist as the panelist. Our first panelist is Padma Shri Dr. G. Vijay Raghavan. He is the Vice Chairman and Founder Director of Kerala Institute of Medical Sciences and President of the Society for Contributing Medical Education and Research, Trivandrum, Kerala. He was honored by Government of India for his services in the field of medical sciences by awarding him Padma Shri. Our second panelist is the respected Dr. Survo Banerjee. Sir is a senior consultant interventional cardiologist practicing in Apollo Hospital, Kolkata. He is one of the contributor in the recently last published heart failure guidelines, which was published in CSI. So with this, I request Dr. Akshay Desai sir to kindly start his talk on the recent updates in heart failure management. Sir, over to you.
Thank you very much, Dr. Komal, and thank you very much for including me in this esteemed panel. I'm honored to be included with Dr. Banerjee and Dr. Vijayaraghavan. I am just going to share my slide deck here with you. Can you see the slides? Perhaps not yet. Let me see sharing screen now. Now it should be visible.
Yes, sir.
Great. So the goal here for the next 30 to 35 minutes is really to walk you through some of the more recent updates in the management of heart failure with reduced ejection fraction. And just for a teaser, I'll close with a few thoughts on evolving therapy of HFpEF, maybe to stimulate some of our discussion. These are my disclosures. Three goals really overall for the talk. The first is to really highlight the profound benefits of pharmacologic therapy in patients with heart failure and reduced ejection fraction and the mandate for initiation and titration of guideline-directed therapies for that population, even in apparently stable patients. I want to talk a little bit about how to do this in clinical practice, how to manage some of the common issues that arise, and then talk a bit about recent updates, as was mentioned in pharmacologic therapy, and some of the new evidence regarding therapies you already know. So a big agenda for a short time, but I hope it will stimulate an exciting discussion. So I think we increasingly understand the progression of heart failure in patients with reduced ejection fraction as not merely the consequence of sustained maladaptive neurohormonal activation, but a problem of restoring neurohormonal imbalance in patients with heart failure. So we've long understood that certain deleterious neurohormones like angiotensin metabolites, sympathetic nervous system metabolites are responsible for some of the progressive fibrosis, hypertrophy, fluid retention, and vasoconstriction that we understand as the progression of the heart failure syndrome. What's been less understood is the compensatory response that happens endogenously, partly because we've not until recently had therapies to deliver to augment that response. But these systems, the natriuretic peptide system, the nitric oxide, the prostaglandin and bradykinin system really counteract some of the deleterious effects of the red neurohormones on the slide to promote vasodilation, diuresis and natriuresis, and have anti-hypertrophic and anti-fibrotic effects. And so the thought increasingly is that if we can inhibit the red and augment the green, then we might be able to restore balance and improve clinical outcomes. The best evidence that this is the case is from the Paradigm HF trial, which I won't review because you all know the results well, which suggests that this combination of neprilysin inhibition to augment circulating levels of natriuretic peptides with an angiotensin receptor blocker bested an ACE inhibition alone as a strategy for management in patients with predominantly mildly symptomatic class 2 heart failure. I think what this slide is shown, it's often shown to emphasize the profound reduction in clinical events, nearly 20% in the primary endpoint with sacubitril/valsartan, then called LCZ6, and the low number needed to treat. But I think what's often missed is really the event rate in the control arm of the trial. This is an active comparator trial with the best medical therapy at the time, including an ACE inhibitor at target dose. And you can see that if you look at the event rate at 1 year in the red line, the event rate approaches 16%, which means that 16% of well-treated patients in this population in the control group had an event at a year, which is really an unacceptably high rate of residual risk that is reduced dramatically by treatment with substitution with sacubitril/valsartan. This benefit is seen early in the trial, and this is an expanded Kaplan-Meier curve looking at the first year. And you can see that by 1 month, the event rates favor the sacubitril/valsartan arm, and that the precision of that estimate starts to approximate the final result by 1 year. Other endpoints that were examined in the trial were all favoring sacubitril/valsartan, including the individual components of the primary and overall mortality, which was reduced by 16% in patients allocated to sacubitril/valsartan. The effect on death was equally seen in the 2 key components of cardiovascular death, including death due to heart failure and sudden death. And this effect on sudden death really speaks to an effect on the substrate for ventricular arrhythmias, because the magnitude of benefit was similar in those patients who were treated and not treated with a defibrillator at baseline. So what is clear is that the drug has greater benefits than ACE inhibition alone, and that neprilysin inhibition has a peculiar benefit in patients with HFrEF. The mechanism of that benefit, however, remained unclear at the end of PARADIGM. The guidelines have embraced the data from PARADIGM to adapt and integrate neprilysin inhibition into the strategic arsenal for patients with heart failure and reduced EF. And you can see in the European guidelines that there's still a favor for older therapies up front, ACE inhibitors and beta blockers, then the addition of an MRA, and then a consideration of ARNI. I think the question of whether this sequencing is the right sequencing for many patients is really called into question from some of the newer data that I'm going to show you. The American guidelines, by contrast, are a little more liberal in their guidance about use of ARNI, and suggest that ARNI might be used as foundational therapy on par with ACE inhibitors and ARBs for patients with low EF. But I'm going to show you some data about utilization of ARNI in ACE inhibitor naive patients, and also show you some data about sequencing that might be informative for your practice. So here's the first question really is, what is it, once you have an ACE inhibitor, an ARB, and a beta blocker on board, does it make sense to go to an MRA or to switch to an ARNI as a first step? And although this is not a prospective randomized trial, I think it's an interesting secondary analysis of PARADIGM-HF that we did, which is if you looked at the subset of patients, nearly a third of patients in the trial on MRAs at baseline in the PARADIGM-HF trial, and then looked at the effect of randomization on serum potassium, you can see the rate of rise of potassium was much greater in patients in the enalapril arm than in the sacubitril/valsartan arm. And if we looked at the incidence of severe hyperkalemia defined at a threshold of 6.0 or greater, a really clearly high potassium, that was most likely to occur in patients on the combination of an ACE inhibitor and an MRA, much less likely to occur on the combination of an ARNI and an MRA. And this suggests that the tolerability of MRA might be better on the background of neprilysin inhibition than on the background of ACE inhibition alone, and might argue for an inversion of the sequencing recommended in the European guidelines. So I think the tolerability of MRA might be enhanced on the background of an ARNI. The other message I think that's critically important from the secondary analyses of PARADIGM is this analysis, which I think may not have gotten the attention it deserves. And this analysis really speaks to the question of whether the stable patient benefits any less than the unstable patient from switch to an ARNI. And so how do we define stability in heart failure? Well, one way to define stability is how long has it been since your patient with heart failure was required hospitalization? The most stable patients are presumably those who've never been hospitalized, and we had a number of those in PARADIGM. And then we can define stability as a function of the time since hospitalization as shown in the slide. And what I'll draw your attention to is that the effect of sacubitril/valsartan is entirely insensitive, very consistent, as shown in the orange vertical line, across these categories, suggesting that the degree or the time since hospitalization is not a determinant of benefit. Now, we can look at this index of stability in other ways using the MAGIC risk score, which segregates risk of patients across different categories. And again, the message is the same. The effect is entirely consistent, independent of symptom severity, independent of overall risk, and independent of apparent stability. And I think we are learning that stability is really a misconception in heart failure, that even the patient who's mildly symptomatic in front of you, remember this population, is not all that stable. So 20% of the patients who'd never been hospitalized but were randomized in Paradigm had a primary event. And during the course of the trial, 17% of those patients died. And of the stable patients, those never hospitalized, who were randomized in the trial and experienced a primary event, death was the first event in about half. And 60% of those were sudden deaths. So what does that mean? I know this is a difficult concept to absorb quickly. The concept is that this patient who came to you in clinic and said, I haven't been hospitalized, I feel well, I might have a little shortness of breath when I ascend the stairs, that patient is at risk for death as a first event and sudden death. And we miss an opportunity to moderate that risk if we don't aggressively utilize guideline-directed therapies, including neprilysin inhibitors. So waiting for your patient to get worse until you make a switch in therapy is probably not an ideal strategy, because we may miss an opportunity to benefit. And this is certainly true of the switch from an ACE inhibitor to sacubitril/valsartan. It's likely true of utilization of other categories of GDMT as well. Now, what do we know about mechanism? Because the big question that came after Paradigm was, yes, the drug is clinically beneficial, but how does it work? And it was an unusual step that was taken with the development program for sacubitril/valsartan to go to phase 3 without a lot of data in phase 2 about remodeling. And so we've now retrofitted that data with 2 trials, one called Evaluate, which I had the pleasure of leading, and another called Prove-HF, and I'll walk you through that data. The design of Evaluate is shown on the slide. It is a very similar design to Paradigm, minus the run-in period. Patients with chronic heart failure, reduced EF, included class 1 as opposed to Paradigm HF, and the blood pressure inclusion criteria were a little higher in this trial. The primary endpoint here was actually measurement of central aortic stiffness, which is a determinant of pulsatile load and pulse pressure, and also a major determinant of ventricular remodeling and cardiac function. So the other endpoints, though, that were examined were endpoints of ventricular remodeling by echo and cardiac biomarkers, as well as quality of life. Patients were randomized for 12 weeks to sacubitril/valsartan or enalapril, and then there was an open label exposure to sacubitril/valsartan for an additional 12 weeks. The primary results of this trial were neutral. There was no effect of sacubitril/valsartan compared with enalapril on the primary measure of the primary endpoint at 12 weeks. Both arms had a subtle decrease in aortic impedance, which was the primary measure of central aortic stiffness, but the between group difference was null. So no effect on the primary endpoint, so we have to be cautious in our look at secondary endpoints, but some very interesting changes in some of the key secondary endpoints. So this is echo, looking at end diastolic and end systolic volume in patients allocated in red to sacubitril/valsartan, in black to enalapril. And you can see that whether we look at ventricular volumes or atrial volumes, the effects all favor sacubitril/valsartan. This is a very early time point, 12 weeks, 3 months after randomization, and we're seeing improvements in ventricular size and atrial size in the sacubitril/valsartan treated patients. And so this is evidence of an early and potent remodeling benefit and changes in structure and function with administration of a neprilysin inhibitor. Now, this effect in Evaluate previews the effect over longer-term exposure seen in the single-arm Prove-HF trial. So this is an uncontrolled trial looking at new initiation of sacubitril/valsartan and comparing change in EF from baseline. And here you see the same effects on ventricular volumes on the right panel, end diastolic and systolic volume reduced gradually more than we saw at 12 weeks, at 6 months, and even further at 12 months. And these effects parallel those seen with beta blockers, for example. And here now, we didn't see an effect on EF in Evaluate, but here over a longer term exposure, now pretty profound effects on ejection fraction, almost a 10% change in left ventricular EF for the Prove population by 12 months. And in fact, nearly a quarter of patients in Prove had an EF change of more than 13% by a year. So these are evidence now from 2 trials of pretty potent effects on ventricular substrate remodeling that might account for some of the clinical benefits seen in the trials. Same effects in Prove seen on left atrial volumes and on diastolic function, and even some effect on left ventricular mass, building the case for a reverse remodeling effect. Now, what about quality of life? Well, we knew from Paradigm that not only were there profound effects on clinical function, but there were some effects on the way that patients felt. And this effect is really even more pronounced in the Evaluate trial, where there was no run-in period. So in Paradigm, the effects were blunted a little bit by the fact that prior to the study, every patient was exposed to sacubitril/valsartan. In Evaluate, the randomization was cleaner, no run-in period, and we get a cleaner effect of the pure effect on quality of life. And you can see here that by 12 weeks, again, a very short time interval, a marked improvement in quality of life. If you're not used to looking at these scores, you should think of a 5-point change as clinically meaningful, a 10-point change as dramatic. And you can see that there's nearly a 10-point change from baseline in the sacubitril/valsartan arm, a lesser change in the enalapril arm, and a between group difference of about 5 points favoring sacubitril/valsartan, suggesting a dramatically improvement quality of life in the sacubitril/valsartan treated patients by 12 weeks. That effect is consistent across all domains of the KCCQ score, suggesting improvements in function, in physical capacity, in social interaction, in sexual function even over time with sacubitril/valsartan compared with enalapril. And though if we ask how many had a clinically important improvement or a clinically important worsening, that also favors sacubitril/valsartan heavily in all categories. So the message is that not only is there an early benefit clinically, there's an early hemodynamic benefit, an early remodeling benefit, and an early benefit on quality of life that increases the urgency for utilization of this therapy in practice. And this is a way to summarize really the net effect, emphasizing that probably the foundational therapy increasingly for most patients with HFrEF ought to be an ARNI plus a beta blocker and an MRA, where the drugs can be tolerated. And this is sort of a sequential addition of medical therapy against imputed placebo, suggesting that that combination compared with placebo in a HFrEF patient probably reduces mortality by up to 60%. Same effects on sudden death have been seen with sequential application of GDMT in clinical trials. This is data from John McMurray's group, published in 2017. And I think the big tragedy of medical therapy for heart failure with reduced EF is that although this benefit is so potent and profound, we underutilize these therapies heavily in clinical practice. The red bars in this registry from the United States, our largest registry about utilization, suggest that at least in the US, in every category, a lot of eligible patients are not receiving the therapies that they should be receiving, at least according to guidelines. And the underutilization of MRAs and ARNIs in particular is really quite substantial and reflects a lot of opportunity for quality improvement. I think the US is unique in this regard. I think we underutilize MRAs more than the rest of the world for reasons that are still unclear, but the same is true really in global exposure, that in general, therapies that patients should be receiving are underutilized. And that gap in implementation is even more profound when we look at dose. So this is again the same data by category. The red sectors in each pie reflect the proportion of eligible patients who are treated at less than 50% of the target dose. And you can see that in each pie piece, it's more than half of the patients. So we underutilize drugs not only by category, but also by dose, which means there's a huge opportunity both for introduction of appropriate therapy and for dose titration in the HFrEF population. So how can we improve therapy of patients with HFrEF and enhance application of guideline-directed medical therapy? One strategy is to leverage the hospitalization as an opportunity to introduce and titrate guideline-directed medical therapy. And this is the early data which argues for that strategy from IMPACT-HF. This is a randomized trial of pre-discharge initiation of a beta blocker versus post-discharge physician-driven initiation of a beta blocker. And you can see that over the course of the trial, the usage of beta blockers is considerably enhanced in the patients who had a pre-discharge start of the beta blocker rather than when the start was left to the clinician to initiate post-discharge. So in-hospital initiation of GDMT enhances long-term utilization in practice. We have similar data now from a trial of sacubitril/valsartan versus enalapril in hospitalized patients called PIONEER. And I want to walk you through that study. This was a trial of 881 hospitalized patients with low ejection fraction who were stabilized after initial admission. and then randomized to initiation of sacubitril valsartan or enalapril at target doses. About 30% of the patients by design were patients who were not previously exposed to an ACE inhibitor or ARB. So this is slightly different than our chronic heart failure trials. The primary endpoint here is a biomarker endpoint at 8 weeks, but clinical endpoints were also examined. If you look at the study design, I think it gives a nice roadmap for utilization of ARNI in clinical practice, because in this trial, the utilization and dosing of ARNI was heavily scripted according to blood pressure thresholds. Depending on the blood pressure, patients were initiated either on the lowest dose of enalapril or sacubitril valsartan, or on the middle dose of sacubitril valsartan, and dose titration was then guided in stepped fashion by the response in blood pressure. So this slide, which we can provide to you subsequently, or you could see in the publication that is listed on the slide, gives you probably a roadmap for how you might utilize the drug according to blood pressure in your clinical practice. But I think the question really is what happens when you do this in hospital to patients post-hospital discharge. And the effect is really more dramatic than we might have imagined. The effect on biomarkers is certainly profound, and that was the primary endpoint in this trial. At 8 weeks, a marked reduction in NT-proBNP in those allocated to sacubitril valsartan versus enalapril. But what was unexpected and really quite dramatic is the 40% reduction in clinical events at 8 weeks post-hospital discharge in the sacubitril valsartan treated patients. A post-hoc result, but one that was highly significant. So a marked improvement in clinical outcomes very early on from pre-hospital discharge initiation of sacubitril valsartan. Now, I told you that this trial by design allowed patients who had never previously been exposed to ACE inhibitors and ARBs. Some of these patients probably had new onset heart failure. And you can see that in that subgroup of patients, that there was a marked reduction in NT-proBNP and a similar reduction in clinical endpoints favoring sacubitril valsartan. And this starts to build the case that these patients who are naive to ACE inhibitors and ARBs derive similar benefit and similar safety from sacubitril valsartan compared with ACE inhibitors and ARBs, and begins to invert the paradigm in our guidelines, suggesting that maybe foundational therapy could begin with an ARNI in some patients who have adequate blood pressure, as opposed to an ACE inhibitor or ARB. The other evidence for that is really this data about dose. And we knew from Paradigm that at any given dose level, a low dose, a middle dose, or a high dose, sacubitril valsartan is preferable to enalapril. And the same data comes out when you look at NT-proBNP effects in PIONEER-HF. And if we look more closely at this low dose group, you can see that there's a marked reduction by 4 weeks that approximates the benefit at 8 weeks in the lowest dose group of sacubitril valsartan. And I think this gives us comfort that in those patients who can only tolerate the lowest dose of sacubitril valsartan, that there's still a lot of the benefit, at least in terms of biomarkers and perhaps clinically. And we know certainly that there is a benefit even in the lowest dose group compared to low dose ACE inhibitor of sacubitril valsartan on CARD clinical endpoints. So I think where you're getting the patient on the drug quickly and getting them on at any tolerated dose, even the lowest dose, has clinical benefit as proven in these trials. Benefit's pretty consistent magnitude. So the problem of aggressive use of sacubitril valsartan as opposed to ACE inhibitors and ARBs, really upfront combination therapy as opposed to monotherapy, is really the potential for hypotension. And so I guess the question is really, how in clinical practice should we address hypotension in patients treated with sacubitril valsartan? And I would put it to you that in my practice, we don't make any dose adjustments for patients who are asymptomatic but have low blood pressure. And I think we can tolerate blood pressures as low as 90 millimeters systolic or even high 80s systolic without really making dose adjustments in patients who do not have symptoms of orthostasis, dizziness on standing, lightheadedness, or symptoms of fatigue or profound intolerance or changes in renal function that indicate hypoperfusion. In patients, by contrast, who are symptomatic, we need to think about a strategy for how to manage that blood pressure reduction. Realize that the effect of sacubitril valsartan in part is related, we think, to a natriuretic effect from enhanced natriuretic peptides. And so it may be the case that patients are a little volume depleted on initiation of sacubitril valsartan, might be a little more vulnerable to hypotension. So my strategy is first, in any patient with hypotension initiated on sacubitril valsartan, is to look at the full medical regimen and eliminate any non-essential medications that may be affecting blood pressure. Calcium channel blockers are a prime target in this regard. I then think about reducing the dose of the loop diuretic, if that's possible, and then think about backing off or discontinuing sacubitril valsartan as a next step. I think there are other strategies, including substitution of less vasodilating beta blockers. I think many of our low blood pressure patients are probably better candidates for drugs like metoprolol or bisoprolol than they are for carvedilol because of that extra vasodilating effect that may limit the blood pressure room for introduction of potent therapies like ARNIs. But I really think I want to discourage you from too quickly discontinuing the neprilysin inhibitor because of all of the potent benefits I've shown you. I'm going to shift gears for a moment now and talk about two other topics briefly. One is the introduction of SGLT2 inhibitors and the way these drugs might interact with usage of neprilysin inhibitors in HFrEF. And then I'll close with a brief comment just to stimulate discussion about HFpEF. All of you are familiar with the profound impact that this new class of SGLT2 inhibitors has had on the management of patients with diabetes. And that data comes from now consistent impacts across 3 large clinical trials of patients with diabetes and high cardiovascular risk, including EMPA-REG OUTCOME, CANVAS trial, and DECLARE TIMI 58, trials of 3 different SGLT2 inhibitors. And the message is remarkably consistent across the trials that whether or not you have a history of heart failure, the impact on incident heart failure in these trials with SGLT2 inhibition in diabetes is pretty consistent. So that observation that the effects are similar in patients without heart failure and those with established heart failure, the observation that that effect is insensitive to the degree of glucose reduction or reduction in hemoglobin A1C, and the observation that these drugs are quite safe with low risk of hypoglycemia, even in those with starting low levels of hemoglobin A1C, really provides the rationale for the DAPA-HF trial. The DAPA-HF trial randomized several thousand patients with heart failure and reduced ejection fraction treated with optimal medical therapy. And in this case, it was truly optimal. 90% treated with an ACE inhibitor, ARB or ARNI, 90% on a beta blocker, 70% on an MRA. And you can see that the addition of dapagliflozin to placebo, compared with placebo, was associated with a 26% reduction in the composite primary endpoint, highly significant number needed to treat of 21. This result mirrors, in some sense, the effect of sacubitril valsartan in PARADIGM-HF. So I think the question becomes now how to integrate, if this result is validated by the other trials that are ongoing, including the empagliflozin trial of EMPEROR-Reduced, then how will we integrate use of SGLT2 inhibitors in tandem with neprilysin inhibitors? Now, before I get there, I want to tell you that the effect here is consistent remarkably in the 50% of patients that by design were included in DAPA-HF without diabetes. And you can see the point estimates line up overall precisely. And this is quite remarkable because it means that a drug developed to lower hemoglobin A1C is actually improving heart failure outcomes in patients without diabetes. I think this conclusively suggests that these drugs are heart failure drugs that happen to lower blood glucose and not really principally drugs for diabetes. Now, the effect in patients treated and not treated with an ARNI is obviously of interest because if these drugs become recommended therapy for heart failure with reduced EF, independent of diabetes status, our question will come up about how to sequence these therapies and who should get which therapy. And I think this data is interesting because there were 11% of patients in DAPA-HF who were treated with an ARNI at baseline. And you can see that the effects of dapagliflozin are consistent in patients treated and not treated with an ARNI. So what does this mean? It means to me that the drug effects are likely to be additive in patients with heart failure, not substitutive. So in general, if you were treated with an ARNI, you got benefit. If you were not treated with an ARNI, you got benefit. This does not speak to an overlap in the treatment effects between the drugs. And I think we're increasingly moving to an era in which foundational therapy for heart failure with reduced ejection fraction, rather than this traditional 3-drug regimen of ACE, beta blocker, MRA, is likely a 5 or a 4-drug regimen if we use sacubitril valsartan, including a neprilysin inhibitor and an SGLT2 inhibitor for the patients that can tolerate them. But this is speculative because our guidelines haven't emerged and we don't yet have the labeled, we have FDA approval in the US now for use of SGLT2 inhibitors, but not insurance coverage. So I think the guidelines still need to speak about how best to integrate this data. And perhaps we should pause a little bit on use of SGLT2 inhibition uniformly in the non-diabetic populations with HFrEF until we have confirmatory data from EMPEROR Reduced, but it certainly seems to be going that way. Now, the other group where SGLT2 inhibitors seem to be emerging as potentially powerful therapy is in HFpEF, where we don't have a lot of data yet, but there's a lot of interest. And so I think it becomes important then to ask the question about what do we know about sacubitril/valsartan in HFpEF, because that's our most recent trial. So I just want to make sure you're aware of the PARAGON-HF results, and maybe we can talk a bit more about them in our concluding discussion. And I think just to remind you, PARAGON-HF was a design very similar to PARADIGM-HF, but now in a HFpEF population, patients with clinical heart failure, elevated natriuretic peptides, and EF more than 45%. And this was randomization to sacubitril/valsartan or valsartan as an active comparator. And in general, there was a numerical reduction in clinical events in the patients assigned to sacubitril/valsartan over total follow-up. But that effect, which was a 13% reduction, just missed the margin for statistical significance. So if you're a statistical purist, this was strictly speaking a neutral result. But in my estimation, it's more likely a borderline result, because if we'd done this trial 1,000 times, it's possible the p-value might have been just to the left of 0.05 in another experiment. But overall, the effect is a borderline result. But I think it really suggests that maybe there's some benefit in this population in heart failure hospitalization reduction. What is seen in that trial, interestingly, is an effect on renal function, and this replicates an effect on attenuation of renal function decline seen in PARADIGM-HF. The same effect here, driven principally by the effect in decline in eGFR rather than on hard renal events, but really a profound signal that neprilysin inhibition may have beneficial effects on protection of renal function in patients with heart failure, independent of ejection fraction. I think what's most interesting about PARAGON-HF is the subgroup analyses. And I'll preface this with a comment that all subgroup analyses in the setting of a neutral overall primary result need to be considered hypothesis generating. But these subgroups were ones that were very hard to ignore, because even after extensive multivariable adjustment, the variance and the interactions persisted. And the two subgroups of interest really in PARAGON are the gender subgroup and the EF subgroups, because women in PARAGON-HF seem to get a much greater benefit than men, and patients with EF below the median seem to get much greater benefit than those patients with an EF above the median. So how do we see that or understand that in practice? Well, if you look at the effect of sacubitril/valsartan compared with valsartan in PARAGON as a function of ejection fraction, you can see here that the dark curve, which represents the treatment hazard ratio favoring sacubitril/valsartan below the orange line, reflects benefit. Seems to suggest benefit continuously with sacubitril/valsartan across the spectrum of EF in PARADIGM and PARAGON. This is pooled data from the two trials, up to an EF of about 55 or 60%. And so there is a continuous effect of sacubitril/valsartan across the spectrum of ejection fraction that seems to obtain up to the very highest ejection fractions where the effect seems to wane. And this effect is even more pronounced if you look at the variance across gender. So this is that same effect in a pooled analysis of PARADIGM and PARAGON. Continuous effect of ejection fraction on the treatment hazard ratio. Blue reflects men, red reflects women. And here is the spectrum of bandwidth of ejection fraction where there appears to be benefit in men. And here is the bandwidth of ejection fraction where there appears to be benefit in women. And this sort of emphasizes the point that women seem to derive benefit to a slightly higher ejection fraction than men do, if we look at the data across the pooled experience of sacubitril/valsartan. And this suggests that there may be something qualitatively different about the EF thresholds for defining HFpEF in men and women. And in particular, that patients in that mid-range of ejection fraction between, say, 40 and 50%, may be patients independent of gender who might derive benefit from sacubitril/valsartan in practice. Now, I must preface this by saying this is an off-label discussion and a secondary post-hoc analysis of a randomized trial with an overall neutral result. So it's largely hypothesis generating, but it does fit with other data from other trials of HFpEF, which suggest that therapies like MRAs and ARBs do seem to have benefit in this mid-range of ejection fraction, even if they don't benefit the overall population with HFpEF. So I'll close with these comments in summary, which really suggest that it is critically important, even in the apparently stable patient, the mildly symptomatic patient, to deliberately introduce and dose titrate guideline-directed therapies, because these therapies have profound impacts on clinical outcomes and are generally underapplied according to guidelines in practice. We've learned from PROVE-HF and EVALUATE that the addition of neprilysin inhibition to ACE inhibition may improve reverse remodeling and actually improve ejection fraction in long-term application, perhaps to the point that some patients who might have required primary prevention defibrillators may no longer require them. Early initiation of ARNI has value because the effects are seen very soon after randomization in all the trials that have been conducted. And even in patients with acutely decompensated heart failure or those who are ACE-ARB naive, there seems to be benefit. The benefit seems to be apparent even at low dose, and the effects seem to be additive between SGLT2 inhibitors and ARNI. Heart failure with preserved ejection fraction remains a challenging problem to treat, but I hope I've convinced you that there may be a role for neurohormonal antagonists, including sacubitril/valsartan, at least in patients with mildly reduced ejection fraction or those in the mid-range. So I hope this stimulates now our next part of the discussion, and I'll stop sharing my slides and hand it back to Dr. Komal to initiate the panel discussion.
Thanks, Dr. Desai, for such an elaborative discussion on the heart failure management. So now we will start with the panel discussion. I request Dr. Vijay Raghavan sir, Dr. Banerjee sir, and Dr. Desai for the discussion. So to initiate discussion, the first question for Dr. Vijay Raghavan sir, the optimal dose of the ARNI is 200 mg there, but in clinical practice in Indian scenario, the physicians are facing challenges in achieving that optimal maximum dose. So your views on this, what is the appropriate methodology to achieve this optimal maximum dose in clinical practice? Dr. Vijay Raghavan sir, please. Sir, please unmute. Dr. Raghavan, please unmute your mic.
Yeah.
Yes. Thanks.
Very important question. So Desai has shown a pie diagram with 50% dose, and I was surprised to find that a good number of patients were on 50% of the dose in the pie diagram in red color. Am I correct, Dr. Desai?
Yeah. Yes, that's correct.
But in spite of the half dose, they benefited significantly. Later, there are slides which shows the half dose and even the quarter dose. See, the problem in India is basically smaller sized patients, low body weight, low BSA. And I found that only about 10 or 20% of my patients could tolerate 200 milligram twice a day of ARNI with valsartan. All other patients, but the 100 milligram twice a day were tolerated by nearly all of them. Ultimately, when you look at the publications, we are not reaching the guideline-directed target dosage. But we find that the benefit is significant, it's phenomenal. We found that benefit is accrued within a matter of 2 weeks. It's progressive. I have found many of my patients becoming quite ambulant, traveling, and looking after themselves. That's a gratifying effect, even though they could tolerate only 50% of the dosage. And the problems that may come in is retitration of the blood pressure drugs, retitration of the diuretics. All these things have to be looked into, plus following up with potassium levels. If you are careful about these things, you find that small percentage of them can go up to the full target dosage, but it's only a small percentage in the Indian patients.
Yeah, thanks, sir. Yeah, so the next question for Dr. Banerjee.
Sorry,
Yes,
Dr. Komal, could I say something?
Sure, sir.
From
I'm
my
coming to you.
Yes. Yeah. See, I think, yes, I mean, as I agree with what Dr. Vijayaraghavan has said, and there have been some concerns about the use of higher dose of ARNI in Indian patients, or any Asian patient for that matter, because of their phenotypically, these patients with heart failure were found to be somewhat different. They have a low body mass index, they have a low systolic blood pressure, and there were concerns whether they would be able to tolerate the higher dose, which I think from the data which we had from the Paradigm Heart Failure study, and we know that about 70%, 17% were Asians, this was not ultimately shown. And it was shown that they could really attend the dose, although this was a very controlled trial setting. Other thing is, but from this concern, I think that many Asians have trials, for example, the parallel heart failure trial among the Japanese, they also started with the lower dose. But I think this is more of a concern. But if you can properly choose and monitor these patients, we may be able to attend the target dose. And two situations arises, I think, where what happens is firstly about the hypertension. Whenever we find that the blood pressure drops, and people are a little bit afraid that some hypertension may happen, and they stop actually up titrating the dose. But again, hypertension is not hypoperfusion. So even if the subjects are doing fine, if they're not hypoperfused, I wouldn't really worry about the reduction in the dose. And secondly, a similar thing is about the renal effect, like the creatine may rise a bit. And again, we may be apprehensive that it's going into renal failure. But again, I don't think it is. And Dr. Desai would probably correct me if I'm wrong. But I think this only shows that probably the drug is having its effect. And most of the time, as we see, it plateaus. I mean, or even with time, it can get better. Both the renal function as well as the fall in blood pressure, they often stabilize after some time. So I think these are the messages we need to also get across, so that people actually, they are more aware of how really they should up titrate the medications.
No, I think well said by both. And the only small point I would make is that, as was just to emphasize what Dr. Banerjee has said, is that if you look at the effect of sacubitril valsartan according to body mass index, there's not a lot of variation in either tolerability or efficacy. So I think just the smaller patient in front of you doesn't mean that the tolerability will be less. And I think it just underscores the need for a deliberate effort at dose titration in every patient. Using blood pressure as a guide, I think if you want a roadmap about how to utilize blood pressure to guide the dosing, I think the Pioneer algorithm gives you some sense of how to do that. But I think sometimes we give up on the opportunity for dose titration based on the assumption that patients will not tolerate medicine. But I think you really need to prove that patients don't tolerate dose titration before you make that conclusion.
I think many patients are quite comfortable between a systolic blood pressure of 80 to 90. If they're comfortable, physiologically, they are looking after themselves, I think that's the blood pressure with which you can leave them alone. But below 80 is something which I don't want the patients to have, because we don't know what will happen in very basic scenario in the day-to-day life. That's where we look at, are we doing the right thing?
Thanks, sir. So we will move to the next question. So the next question to all panelists is, Dr. Desai in his presentation highlighted on the Pioneer HF trial data and also the early initiation of ARNI in ADHF trial. So I request Dr. Banerjee, sir, your views in clinical practice, should we start directly with ARNI instead of ACE or ARB, or should we wait and then shift? So your views on this.
Yeah, it's a good question, actually. I think if you look at the guidelines, probably we are still not really, we have that freedom. But again, if you ask me, as Dr. Desai has shown in his talk, in his the slides, like on the Pioneer AF study, there's about a fraction of patients were naive for ACE and ARB. And actually, they did as good as the rest of the population who are on ACE and ARB. So considering this, I think we should change the guidelines and should initiate the ARNI earlier, so that we do not waste the valuable time. That's actually, we are procrastinating starting ARNI, and that's why maybe we are saving less number of patients. So I think that is something which I would suggest. And on this, I have a question for Dr. Desai, if I'm allowed to do that. That you see, if the slides you showed there, if you look closely at the hazard ratio, there were actually, it was better for those who are naive for ACE and ARBs rather than those who are not. So does it mean that there is a signal that these patients could even do better? That is, the ACE or ARB naive patients could do better or ARNI than those who are already on ACE or ARBs.
Yeah, no, it's an interesting point. You're absolutely right about that numerical difference favoring the low dose, the ACE-ARB naive patients. Statistically, when you look at the interaction, there is not a variance in the effect. So it's hard to say that those numbers are statistically different. But I agree, numerically, it does give that impression. I don't think we have definitive data to say that, but I wholly agree with your approach, which is the only rationale I can see for sequential addition of ACE inhibitors and ARBs is a tolerability rationale, right? Which is the same argument we make for any initiation of combination therapy, that if patients you're concerned about tolerating the medicine because of marginal blood pressure, marginal renal function, then I think it's not unreasonable to say, I'm going to start with an ACE inhibitor ARB, prove they can tolerate it, and then make the switch, as long as you commit to making that switch. I think in patients with good blood pressure, sturdy blood pressure, reasonable renal function, there really is not a very compelling rationale for not just starting up front with the ARNI, because we now have enough trial data to suggest that strategy is safe and that it's effective, and that the effects, as you said so eloquently, are seen very early. And I think we don't want to miss the opportunity. So in my practice, I am starting, although you're very correct to point out the guidelines are a little behind us in that regard.
Thanks, sir. Dr. Vijay Raghavan, sir, your views on this?
I have, I would say, once again, starting early, yeah, ARNI instead of starting on and spending time on ACE inhibitor ARBs. This also contains ARBs. So I normally start the valsartan sacubitril combination, because I find nothing against that combination, rather than waste time on ACE inhibitors, ARBs, and wait for its full action to come in. Straight away start it.
Yeah.
Yeah. Thanks, sir. So the next question for all the panelists: how early do you see improvement in the quality of life with ARNI in the clinical practice? So I request Dr. Raghavan, sir, to share your views on this.
See, many of these patients whom I start treating with ARNI are patients already on ACE inhibitors or ARBs. But starting on the combination of valsartan sacubitril, the sense of well-being is usually seen in about 3 to 4 weeks' time. They come and tell you their ability to do more work, the ability to walk is far better. That sense of well-being is what I expect out of those patients, because they feel this is a different drug. Good old days when we introduced beta blockers, this is exactly what they told me. A sense of well-being they found when we used beta blockers. This was back in late 80s and early 90s. Same feeling they have with this combination of ARNI and this combination drug ARNI. And then such patients often do not have any objection when you step up the dosage. But it's the parameters that you measure that limits you from going to 200 milligrams. And because there's a warning that tells you, are you doing the right thing to the patient or not? By raising, patient is already feeling better. Do you want anything more? Is the next question, just because the literature says it's better to use the full dose of 200 milligrams. That's why only about 20% of my patients are on 200 milligrams twice a day, while 80% are on the lower dosage. I'm very happy to see the pie diagram of Dr. Desai, which showed that a lot of those patients were on the dosage with really good benefit.
Thanks, sir. Dr. Banerjee, sir, your views on
Oh, absolutely. I agree with already what Dr. Vijay Raghavan has said. And I think initially I was quite surprised to see like the patients actually reporting symptomatic improvement. And I think often they come before the clinical improvement. But yes, I mean, patients who actually do well on that, they want to stick to the medication. Could I ask a quick question to Dr. Desai before you go to the next question? And that's an interesting thing. You showed the Paragon heart failure slides, and there you did show like how ejection fraction has a relation to the age and to the sex. So do you think, since ejection fraction is a central, central to the decision-making process about the management, should we be should we have a relook into how our ejection fraction is defined, and actually think about whether whether ejection fraction should be defined as more age and gender specific?
I think this is a really provocative point, and I'm not sure I have a definitive answer, but I think that what is the case that we know from the literature is that on average, in epidemiologic series, women have higher ejection fractions than men do, and there does seem to be, for any degree of function, a variance, but that is gender specific. And it does, in the data in that analysis I showed you, that suggests different effects based on the cross of sex and ejection fraction on the efficacy of sacubitril/valsartan, does raise this question of whether we should be defining HFrEF, for example, with different cut points in women and in men. I think that that's all sort of a post hoc analysis of the trial, and I think requires some validation. But as I mentioned at the tail end, if you do the same analysis by continuous ejection fraction of other trials of heart failure with preserved EF, like the TOPCAT trial of spironolactone or the CHARM trial of candesartan, the same patterns by EF at least seem to exist. The gender interaction we haven't examined. And so there does appear to be this variance by ejection fraction and this continuous effect up to a slightly higher EF than maybe we've done. And I think one of the lessons I take more, I don't know about whether we need to revise gender thresholds for EF, although there's a suggestion, as I mentioned, but I do think it raises the question of whether we've been too restrictive in our definition of what constitutes a low ejection fraction in heart failure. Because if the benefit of these drugs, spironolactone, ARBs, angiotensin receptor neprilysin inhibitors, obtains to EFs upwards of 45, 50%, then maybe it's the case that we should just have two categories of patients, those with subnormal ejection fraction and those with truly normal ejection fraction. And if you're in that subnormal group, whether your EF is 40, 45, or 49%, perhaps you should still get the standard neurohormonal antagonist therapies, including sacubitril/valsartan. Now that is largely a significant extrapolation from aggregate data across the trials, but I think it's defensible as an argument. And the guidelines have called out this group of mid-range patients with an EF between 40 and 50%. And I think Professor McMurray, Dr. Solomon, Carolyn Lamb, others have really highlighted that this group of patients we've called mid-range may just be mildly reduced patients who stand to benefit from the same therapies as patients with HFrEF. And if that's the case, maybe that's a takeaway from this. The gender issue, I think, is one that needs to be unpacked further. I don't know, Dr. Vijayaraghavan, if you have other thoughts there.
I was wondering, the ejection fraction has a lot of subjective involvement, while global longitudinal strain may replace many of the ejection fraction concept in many researchers in future, as will the clinical practice, because global ejection fraction is objective and not subjective. This may replace in future, and we have to wait for that, because all the standardizations and definitions are to come in. What is normal, what is abnormal, and what is the preserved one.
One other thing I might mention that, the obverse of, again, we can speculate a lot, but the obverse of saying that women got more benefit in Paragon than men did is to say that men got less benefit than women did. And you might ask the question in reverse and say, why is it that men might benefit less? There are a number of arguments about why women might benefit more, one of which is the EF argument. That is, women in general tend to have higher EF, so an EF of 45 or 50% may be actually reduced in a woman with HFpEF. And women respond differently to neprilysin inhibitors. Women have different response in terms of central aortic stiffness in our Evaluate trial. So there are a lot of reasons, but men, with the only subcategory of patients that did not get benefit in Paragon tended to be the men with high ejection fraction. And what's interesting is that population probably concentrates people with other diseases that might be less likely to respond to neurohormonal therapies, including amyloidosis. And so one of the questions in Paragon and in HFpEF management in general is the extent to which trial populations are contaminated with undiagnosed senile amyloidosis. And because those patients may have a different pathway for therapy, may be less tolerant in general of vasodilators, there is the question about whether some of the effect that was not seen in men with high EF in Paragon may have been undermined by undiagnosed amyloid that was inadvertently included in the trial. But again, all speculative, but interesting for conversation.
Thanks, sir. So we will move to the next question. In HFrEF patient with eGFR around 35, that is moderate CKD patient, how will you approach with ARNI regarding the use of ARNI? So I request Dr. Banerjee, sir, to kindly give you.
Yeah, I think I will start with a small dose and then check the creatinine and potassium and closely monitor this patient. As I've said, like if there's a slight rise in creatinine, I wouldn't be too much bothered about. I would be more bothered about the potassium. But again, normally I would expect that to plateau after some time. And so at least this, even if it's a borderline renal function, I think I would be cautious. But that doesn't mean that I would not start these patients on ARNI.
Yeah.
Agree.
Yeah, Dr. Vijayaraghavan, sir.
Same thing.
Yeah, sure. So the next question in continuation with this, should we wait for the patient for switching from to decompensate for switching from ACE to ARNI, or should we directly shift on ARNI in such patients?
I think we have discussed that point already.
Sure, sir.
Starting directly on ARNI has no disadvantages at all.
The other thing I might just remind folks on in regard to that question, and I think we mentioned this, is that I think that the waiting for decompensation strategy is really not a very proactive strategy. And the analogy I often use for my patients is that, we've treated blood pressure and hypertension for a long time, and we know that having a blood pressure of 170 for a period of time is not going to be damaging for the patient, but over the long term, we don't want to leave that risk unattended. And similarly, in a patient with chronic heart failure, we want to manage all of the residual risk that's in front of us. And one way to augment our understanding of risk in patients is to measure biomarkers like NT-proBNP or BNP in those patients. And I think you will see, even in your low EF patients who don't report a lot of symptoms, that many of those patients have BNP levels that exceed 1,000, NT-proBNP levels that exceed 1,000, marking their residual risk for clinical events. So I think that while we don't utilize natriuretic peptides to guide therapy, I think if you're wondering whether the patient in front of you is stable or not, maybe that might help augment your strategy. But my perception is that no heart failure patient is truly stable, and that waiting for decompensation is really missing the boat. The final issue is that the quality of life improvements are really quite early and profound in these patients. And some patients who initiated on therapy may feel better than they realized was possible. So those patients who thought they were asymptomatic, as was eloquently outlined by Dr. Vijayaraghavan and Dr. Banerjee, may actually see even great enhancement in their activity. And I think that's another reason to really push patients to consider the switch.
Yeah, thanks, sir. So the next question is regarding diabetes. Now with DAPA-HF trial, now SGLT2 inhibitors are there in HF management. So what should be the approach to treat diabetic patients with heart failure with this SGLT2 inhibitors data? Dr. Vijayaraghavan, sir?
I was thinking of my graduation days in 1964. Heart failure was very easy to treat. There was only digoxin and mercurial diuretics, nothing else. And complete bed rest. In examination, if you make a patient get out of the bed who is in cardiac failure, you lose your degree. Today you make them walk as much as they can if they feel comfortable. The change is phenomenal.
Yeah. Thanks,
Dr. Banerjee.
Dr. Banerjee.
Yeah, well, I think the question was, I think the ARNI, sorry, not ARNI, is the SGLT2 inhibitors in diabetic heart failure. Yeah,
Yes.
I mean,
That's
I
why
think,
I'm saying.
and yeah, as well, I think why the question I would just modify, like why it has to be diabetic patients now. It could be patients even without a diabetes who were, but in heart failure who could benefit. And we have now a DCGI approval in India. So you are licensed to use dapagliflozin. Now, for the time being, dapagliflozin, at least in patients with heart failure, even they are not diabetic. And if the patients are diabetic, then there are more reasons to use that.
You know, I think I made my thoughts on this quite clear, which overlap with those of the other panelists. But I think that our evolving strategy for HFrEF, independent of diabetes status, is likely to include both drugs. I think that it is interesting because I think in the diabetic population, many of the patients, if we're doing our jobs with diabetes, should be treated up front with SGLT2 inhibitors. So hopefully they'll come to your practice already treated with these drugs. The non-diabetics, though, it may be on the cardiologist to initiate the drug. And I think the data, if it's certainly from DAPA-HF, is compelling and the indication is there. If the data is borne out by EMPEROR reduced for empagliflozin, I think we'll see guidelines move fairly quickly. There's a question here about effects on echo parameters of SGLT2 inhibitors versus ARNIs. We don't have any such data with SGLT2 inhibitors about remodeling, so I think it's difficult to comment. And what's interesting is that although we're evolving an evidence base now about the use of neprilysin inhibitors and its effects on myocardial substrate remodeling, we really have very little understanding of mechanism of action of SGLT2 inhibitors in heart failure with reduced EF, and that data is still evolving. There's a lot of speculation about whether this is an effect that is dominated by a diuretic effect, an effect on tubuloglomerular feedback and renal preservation, an effect on ketosis and change in myocardial energy substrate utilization, a direct myocardial effect on sodium hydrogen exchange. There's a myriad hypotheses out there, but I think we still need more data. But the direct myocardial effects are still being explored, as I understand it.
Thanks, sir. So the next question is regarding the HRF patient with hypertension. If the patient is having BP around 90, systolic BP 90, so how to manage such patients with an ARNI? Should we down titrate? Or what is the management? Dr. Banerjee, sir, your views?
Yeah, I think Dr. Desai has very nicely explained that in his presentation. So of course, we have to make sure there's any reason for hypertension. That is different. So if there's no other reason for hypertension, then we could actually find out what are the drugs that are not necessary. Maybe he's on some antihypertensive drugs, which we can lower the dose or can stop them altogether. Or maybe he's also on some diuretics, which if the patient is stable, otherwise clinically, then we can cut down on the dose. And if it's still the patient is hypertensive, then we have to reduce the dose of ARNI. And only, I think, in exceptional circumstances, we may have to stop it altogether for a temporary period. But again, later we should make another attempt to see if we can reintroduce it.
Can I ask a question to the panelists, just because I'm unaware? Is there a cost difference with utilization of ARNI in India for your patients? Does that drive at all the decision making about selection of therapy, or is it all fairly accessible?
No, it's sorry, Dr. Raghavan.
Pardon?
Sorry, should I say? Okay. No, I was just going, sorry. Over to you, Dr. Vijayaraghavan. You first.
It's not a cheap drug.
Yeah, I agree. It is not a cheap drug. No, it's quite expensive. And so that's, I think, one of the reasons why the uptake of ARNI has been a bit low in India.
It eats into the family budget, patient's budget significantly every month.
Yeah, I think we have the same problem. And I think one of the questions in the chat is really about why it is that the drugs are underutilized. And I think this is one major driver. I think therapeutic inertia is certainly there. And we've talked a lot about that and the need for some sense of urgency on the part of clinicians. But the practical reality is that our patients have to eat before they treat their heart failure, and sometimes that decision is complicated. I hope that as the more drugs are available, the cost is driven down, but it's still a consideration, less so than before in our nation, but it sounds like still a valid consideration.
Thanks, sir. And the last question for Dr. Desai, sir. Recently, this SAFE ICD trial has been published. So, what are the clinical implications of this trial regarding ICD use in relation? Dr. Desai?
Yeah, so I mean, I think that, generally what we're struggling with really is in the evolving era of guideline-directed medical therapy, and that marked reduction in sudden death that has been seen with increasing utilization of medical therapy. I think I showed you that slide from Dr. McMurray's group, is really, should we be revising our understanding of who benefits from defibrillator therapy, particularly in primary prevention? I think there's very little debate about use of defibrillators in people who've had a cardiac arrest or those who have symptomatic ventricular tachycardia and low ejection fraction. But in those patients with no prior event, the rates of sudden death on good medical therapy are going way down, and the urgency, therefore, for primary prevention ICD might need to be questioned. And we have data now from trials in Europe, and then also this other trial that you mentioned that really would suggest that that maybe the benefits, particularly in the non-ischemic cardiomyopathy patients from Danish, need to be revised because there may be less benefit, particularly on good guideline-directed medical therapy in primary prevention. So I think we're beginning to re-examine the value of defibrillators for early prevention of sudden death in the backdrop of aggressive medical therapy. But I'd be interested. The U.S. is very aggressive with use of primary prevention ICDs. I think. More so than the rest of the world. I'd be interested in understanding the Indian practice a little bit better.
Thanks, sir. So this is the last question. And now I request Dr. Raghavan, sir, and Dr. Banerjee, sir, to kindly give the concluding remarks of the session.
I think Dr. Banerjee's lecture did cover a lot of area which has not been highlighted before. For example, I would say, in the HFpEF trial, you found improvement in renal function, in protection of renal function. Some of these areas we had never known. Number two, that pie diagram which I referred to earlier, that 50% of the dosage is good enough in many a patient, and the clinical trial also could achieve only that much of dosage because of the many problems involved. The main thing that Indian patients have always been thinking of, whether this RNA could raise the level of kinins and produce cough. Fortunately, none of the clinical trials it has happened. None of the clinical trials, the cough was a major problem. And I find the new information and the very detailed information, the time of onset of benefit that Dr. Desai has given has been absolutely welcome. And thank you, Dr. Desai, for highlighting those information to us. Thank you.
Thank you.
Thanks, sir. Yeah, Dr. Banerjee, sir, please.
Yeah, I think I'll take this opportunity to thank Dr. Desai for the wonderful and enlightening talk. And I think the take-home message here is, of course, ARNI is a good drug, and it should be started early as soon as possible in patients with heart failure. Once they are, otherwise they fit the criteria for the trial for the time being, for the paradigm heart failure trial, and maybe later we can have more patients who would who are probably ACE and ARBs naive, and we can start them even earlier. And hypertension and renal dysfunction are the things, of course, we have to keep an eye on, but certainly these are not the not the parameters on which you would really think about stopping the medication. And I think the final word should go to Dr. Desai.
Well, you're very kind to offer me that, and it's really been a pleasure to participate in this discussion with such luminaries in India in cardiology. So I'm privileged to be a part of this group and want to thank you for a really excellent discussion. I think the messages are very much as you've summarized them both. The only other argument I would make is that I think we're in a very exciting time for heart failure therapy. And as Dr. Vijayaraghavan said, we've come a long way in a very short period of time. But I think our patients will only benefit to the extent that we apply these therapies in practice. And so I think that in each encounter that you have with your patients, I think it's important to consider the opportunity for introduction of novel therapy, for dose titration of therapy, independent of the apparent risk of the patient in front of you, and to recognize that there is a lot of residual risk in the apparently stable patient. And I think HFpEF is a space to watch. I think we're all struggling with how to better manage these patients. But I hope that the data from Paragon that I've shown you suggests that maybe we're moving towards a segmentation of that population and an understanding of that population that may inform not only future trial designs, but hopefully an approach to better pharmacologic therapy for that population. So more to come. Thanks for your attention. Thanks for the extraordinary attendance at this program and the fantastic questions, and thanks to the panelists and the sponsor.
Thanks, sir. So on behalf of Lupin, I would like to thank Dr. Akshay Desai for such a wonderful presentation on HF management. I also like to thank Dr. Vijayaraghavan sir and Dr. Banerjee sir for sharing their clinical insights on this heart failure management topic. Thank you all. With this, I'll end today's session. Thanks, sir. Thanks a lot.
You're welcome.
Thank you. Bye-bye.
Thank you,
Good to meet you all. Yeah.
Okay. So that,
Same here. Same here.
Thank you.
take care.
Goodbye, madam.